Thank you all for having me here, and it's always a delight and a pleasure to speak at my very favorite patient organization. And as luck would have it, I was putting the final touches on my presentation, and the whole thing crashed. And thankfully, it's still working, so hopefully I won't have too many issues. So today, I want to talk about something that not a lot of people talk about. I think some people are actually afraid of talking about this, and some surgeons may be a little bit afraid of talking about this. So I really want to, it's a subject that's really near and dear to my heart, and I think it's important and somewhat overlooked, which is headaches. Headaches and pituitary tumors, and tumors around the pituitary gland. And you'll see why I'll talk about this in a little bit. Just to give an overview, I think you guys are all pros here, so you already know this, but I'll give you a little brief overview on pituitary surgery and anatomy, and then we'll go forward from there.
Yeah, Dr. Barkhoudarian, we do have a couple new patients, so this is good.
Oh, good.
And also for the video.
Oh, perfect. So the pituitary gland is also known as the master gland. It basically is the most important gland of the body, and it controls many of the hormonal functions of the body. And without it, you really couldn't survive. It controls your ability to combat stress, any stress in life, including bumping your toe, to a severe infection, to the stress of giving a presentation in front of a bunch of people, to metabolism, growth, thirst, electrolyte balance, sexual function, reproduction, and birth. You know, all of those are really governed by the pituitary gland. And so it really is an important structure. And it's really complicated as to how it's wired. You know, it has input from the brain directly to a certain part of the pituitary gland, by blood vessels to another part of the pituitary gland. And the bloodstream gives feedback to the pituitary gland to tell them, hey, wait a minute, there's too much of this or too little of that, and adjust accordingly. It also, from a surgical perspective, is really interesting because it lies kind of at the nexus of the brain, where the hypothalamus, which is this part, the optic chiasm down here, and the carotid arteries intersect. And there's lots of stuff going on. So any sort of issues can occur from the pituitary gland, from hormone secretion from the gland itself, to vision loss, to damage to the nerves or affecting the nerves in this area, to affecting the brain, and so forth. So really interesting types of presentation, very different in everybody. Can be quite interesting to see what we see. This is a nice diagram. This is just a drawing of a normal pituitary gland. It's not exactly accurate, but it's pretty close. And you can see, you know, this is how it should be. It should be floating in its own fluid, and there should be gaps between all these important structures. But when we get a tumor, it starts to press on things. For most tumors, it starts to press on the nerves to the eye, so the optic chiasm, and it can cause vision loss. It starts to press on the blood-filled areas here where there are some nerves, and it can cause other nerve issues, and we'll talk a little bit about that. And it starts to press on the pituitary gland itself. So not only could it secrete hormones, but at the same time it could also cause other hormones not to work well, or it may just affect the gland overall and not make it work as well as you'd like. So how do these tumors present? Well, I think number one, everybody says this on a list, is headaches. People say headaches because it's very common, and we'll talk a little bit more about those headaches. Vision loss or disturbance, as I mentioned, endocrine dysfunction, over or underproduction, or a combination of the above. And this is usually what we see. Usually what we see is that there's a couple of things going on. And sometimes it's incidental. So this is just a diagram that a colleague of mine gave, and it just is a stick figure of what could actually be going on as far as tumors or other processes. And this is just a depiction of the different structures. So this being the gland, this is the bone around the gland, the coverings of the dura, the nerves, the brain, etc. Each of these processes can go wrong, and that can result in either a tumor or inflammation or some process that can be abnormal and needs to be addressed. So we are thinking about a bunch of different things when we're looking at the gland. How common are these? Well, we'd like to say that about 1 in 5 or 1 in 6 people in the whole world have something abnormal in their pituitary gland. And this is based on studying people who've died and looking at their brains, or just getting a bunch of normal MRI scans and seeing how many abnormal findings do we see in the pituitary gland. So it's rather common to see a small little tumor or a little cyst that sits there, and people live with it, people die with it, they never knew they had it. But it's pretty common. Only about 1 in 1,000 of these people actually will need some sort of intervention, whether it's surgery or a medication to help treat their tumors. This is an example. This is a very old picture, and before the time of modern surgery, really, of a microadenoma. So there you see the stalk, the infundibulum of the pituitary gland. This is the normal gland, and here is a microadenoma. Very small, it's blown up in size. This was a patient who had Cushing's disease before we really understood how to treat Cushing's disease, and this patient unfortunately didn't survive as a result of this little tumor. This little 8-millimeter tumor was that person's demise. So we're able to cure this for a number of patients, and we're able to treat them rather successfully in many others. And this is one aspect of disease. This, on the other hand, is a very different type of tumor. And this is the type of tumor we're going to focus a little bit more on. This is a tumor that is not secreting a hormone, but has grown so big that it went up and blocked the normal flow of fluid in the brain, and the brain swelled, and the patient didn't make it. Again, this is a very old image. We don't see this outcome anymore, but we definitely do see the syndrome, and we catch it before it causes problems. There's certain things to think about. So as I mentioned, there's a bunch of different types of pathology that can occur, starting with pituitary tumors like adenomas, but also cysts like Rathi's cleft cysts or dermoid cysts, craniopharyngioma, which is its own beast. It's a very challenging tumor. Meningiomas that can occur all over the brain, but can occur around the pituitary gland and affect the way the gland works. And then some other more unusual things like an epidermoid cyst, which you can barely see there, but it's actually a cyst that was there from birth and causing problems in the brain and just kind of happening to be near the pituitary gland. Choroidomas, which is a bony or a tumor that arises from the bone that can push on the gland or some of the other structures, and even nerve tumors like schwannomas. We, in medical school, have to learn some mnemonics to just get by, to remember things, and the mnemonic for tumors in the area of the pituitary gland is called Satchmo. I remember it because of Westerns, but it's funny, I was just in another country and I said this mnemonic and people kind of gave this blank stare, and I realized it had no idea. Anyway, so this is a short list of what can actually be going on in the pituitary, and so we have to think about all of these. And skip that for a sec. So let's talk about headaches. So according to the International Headache Society, and yes, there is an International Headache Society, there's a specific criteria for diagnosing a headache that's related to a tumor in the brain. And so I'm going to take you through this because it's kind of circular logic. So basically, they say a headache has to have one of the following criteria. It's got to be progressive, localized, and it has to be, or it could be worse in the morning. It could be aggravated by coughing or bending forward, anything that you kind of increase the pressure in your belly or your chest, and that transmits the pressure up to your brain. You have to see a tumor that's visible on the MRI or on the CAT scan. And then it has to have these two. It has to, the headache has to show up when the tumor is present. So you can't have a headache for many, many years and have a normal MRI and then develop the tumor and say, well, that's related to the headache. That doesn't work. And then the headache should resolve within a period of time after removing the tumor or treatment of the swelling induced by the tumor with steroids. So now this is kind of circular logic, right? Because you have a patient with an MRI with the tumor, and the patient has headaches, and the only way you can definitively say that their headaches are caused by the tumor is by removing the tumor or making the tumor go away somehow. So it's very hard to prove this without taking a patient to surgery, but many times we have to sit down and have this discussion. Well, maybe it's causing the headache, maybe not, and then there's a bunch of statistics that we have to talk about. So with regards to that, there's some interesting studies. It's a very old study looking at the different types of headaches that people can get with different locations of tumor. So if the tumor is on the side of the brain, so affecting the vessels in that area kind of near your temple, the headaches are on the temple area. If it's in the back part of the brain, you can get an occipital headache or a neck headache. Sometimes people confuse it with neck pain. If it's down on the floor of the skull in the back, it can actually irritate the nerves, and you can get a really significant pain that's similar to something called occipital neuralgia. You may have heard of that. But the headaches that we see with pituitary tumors are these two types. These are the most common types. There are other types, but these are the most common types. Either headache at the vertex of the head, so the top of your head, or a headache right behind the eyes. And that's kind of the more common thing we hear, is the headache is right here. And that's because the vessels and structures that are affected transmit pain to that area as well. And I'll show you the anatomy of that as well. So this is a study about now 16 years ago that looked at about 280 patients evaluated, and they looked at the quality and the location, duration, and frequency of headaches with any sort of tumor, not just pituitary tumor. And they found that 60% of patients who had a tumor had headaches. So quite a big number. And only 15% of patients had persistent headaches 3 months after surgery. So that means at least 45% or so of patients truly had headache related to their tumor. And most of these patients, 84 or 85% of these patients, the headache did resolve with surgery. And depending on the pathology, there were different qualities of headache. So a progressive headache, so one that's getting worse and worse and worse, tended to be more associated with more aggressive tumors like malignancies, like metastatic tumors or glioblastoma. Whereas those that are non-progressive, just kind of chronic, dull, always sitting there type headaches, those tend to be with more of the benign types, like meningiomas. And that pituitary adenomas and pituitary tumors in general tend to fall into that category. The location of the tumor was also significant, in particular lower down in the skull base, in the back part. It's called the posterior fossa, which is where the brainstem is, and the cerebellum, and those kind of important structures. Those tended to have a higher rate of headache as well. And then the other thing that was going to be important for our talk is the presence of hydrocephalus. And I'm going to talk in depth about what hydrocephalus is. Some of you actually know what that is quite well. But when you do have hydrocephalus, one can get a headache more prominently. So what are the typical types of headaches associated with pituitary tumors? So daily headaches, pretty common. Typically, like I said, at the front or at the top of the head. Typically lasts a few hours in duration, not always present. Can be on one side. Can be moderate or severe, typically, 4 out of 10, 5 out of 10, something like that. A small portion of patients, so only about 15% of patients, actually will wake up because of the headache. So we always like to ask that because that's usually a sign of something bad, but only a small percent of patients actually truly have that. And rarely it could be severe and acute, and we're going to talk in depth about what this is as well. So what are some mechanisms, and we'll go into depth about the mechanisms. We think that it's because of stretching the dura mater. So the dura mater is the covering of the brain, and there's a special covering of the pituitary gland that separates the gland a little bit from the brain. And that can be stretched by any sort of lesion that's in the sella and pushing up or growing up. Interestingly, at least in our studies, larger tumors are less likely to cause headaches than smaller tumors because they are slower growing. So by the time we diagnose you with a larger tumor, it's probably been growing for 10, 15, 20 years. Whereas when we diagnose you with a smaller tumor, maybe it's causing a different type of symptom and not necessarily what would be caused by stretching so much. So they tend to be a little bit more aggressive. And it's also the rate of growth of the tumor. Interestingly, the most common type of tumor that will result in a headache, and one that will get better after surgery, is a cystic tumor. So a Rathke's cleft cyst, not technically a tumor, Rathke's cleft cyst, arachnoid cyst, craniopharyngiomas, and other cystic tumors are more likely to get better after surgery. The headaches are more likely to get better. And if there's bleeding in the tumor, so whether it's pituitary apoplexy, which we'll talk about, or if there was just some bleeding intermittently as the tumor would grow over the years, those headaches tend to get better as well. Also, if there's association with hydrocephalus, and I'll talk a little bit about that. So this is a study that I did with Dr. Laws over in Brigham and Women's Hospital in Boston. And we were looking at the severity of headache. And we found that people who had macroadenomas tended to have, on average, lower severity of headaches for their typical and their most severe versions of their headaches. Smaller tumors actually tended to be a little bit more, but not significantly different. But it was the cystic tumors, whether they were Rathke's cleft cysts or cystic adenomas, that had the more severe headaches. This was a study that looked at the size of a tumor and the incidence of headaches. And this is a really interesting study because they thought that size was really not the key thing with respect to headaches. They looked at 63 patients, only 70%, and 70% had headaches. Many of them actually had hormone-secreting tumors, so acromegaly, prolactinomas, and Cushing's disease were pretty common. This is what they found. There was no correlation with the headache score and the pituitary volume. And you can see the headache score could be quite severe with really small tumors and really kind of bland with really large tumors. So they realized there must be something else going on. One thing was if they were prone to have headaches. So if there was a family history for headaches, then there was a higher likelihood that they would just have headaches related to their tumor. So there's probably a genetic aspect to how we process pain and headaches that can contribute to how one person just gets a mild headache and another person gets a very severe headache for the exact same MRI scan. Also, and I think this is the most interesting thing from the study, is that they found that people who had hormone-secreting tumors, so Cushing's disease, acromegaly, et cetera, when their tumor was removed or when they were just treated with a dopamine agonist, say for example, their headaches actually got better. And it was less likely to get worse. In particular with the acromegalics, when they were treated and their tumor really doesn't shrink too much, their headaches got better. So there was some hormonal aspect to the generation of headaches. So that's basically what I mentioned. So best seen improvement with arachnoid cysts, Rathke's apoplexy, and hormone-secreting tumors. So let's talk a little bit more about these mechanisms because I think this is really interesting, and I'm going to try to prove it to you with what we see here. So I think the most common thing that we think about that would cause headaches is stretching the surrounding structures. But like I said, maybe not the main system because some people have huge tumors and have no headaches. So could be the rate of growth. Maybe it's the nerve, the trigeminal nerve. This is the nerve that supplies sensation to the face and to a lot of the skull. And maybe this nerve can get irritated and that can cause pain or something called trigeminal neuralgia, which we'll talk about. Or maybe the dura, or the covering of the brain, is inflamed. So it could be inflamed more commonly from an infection, but it could also be inflamed from an inflammatory process that could be the tumor that we're looking at, or the lesion that we're looking at. Certainly, increased intracranial pressure can cause headaches, and more general headaches. And when we see hydrocephalus in particular, those headaches can be quite significant, and it's treated a little bit differently. And ultimately, bleeding into the tumor and pituitary apoplexy can result in a specific type of headache. So let's go through each of these. So direct dural stretch. So like I said, the dura is a covering of the brain. So the brain actually has 3 layers of covering, which are the meninges. So when you hear about meningitis and inflammation of these structures, it could be any of these 3 structures. The dura, it's called the dura mater, meaning tough mother. And that's covering kind of the outsides of the brain. And then there's arachnoid mater, meaning that it looks like spider webs. And those are kind of in between. There are different layers in between the bone and the brain. And there's something called the pia mater, which is the really thin part that directly is sitting on top of the brain itself. So what I'm interested in here is the actual dura mater, because this is the part that has nerves in it. The other two don't have nerves, they're painless. So this structure here is all dura. All of this is dura, and this is dura, and this is dura. So you can see that the pituitary gland is surrounded by dura. And the dura, as I said, has nerves in it, and it certainly can get irritated, and sometimes when they get irritated, it can result in pain. So as I showed this picture before, if a tumor gets really big, it stretches these structures and can potentially induce pain. This is a schematic of the way the trigeminal nerve distributes its fibers throughout the face. So this is on the face side, so it's on the outside. But you can see that there's 3 branches, V1, V2, and V3. So that's why it's called trigeminal. So there's 3 branches. And the V1 part, it goes to the eye. V2 kind of goes to the cheek. And V3 goes to the jaw. But this V1 actually goes to the top of the head. So it's not uncommon to get a headache at the top of the head from a pituitary tumor because this nerve is irritated by the tumor. These are other nerves that can go to the scalp that are probably not causing headaches from a pituitary tumor. So it's less likely for a headache in the back of the head to be related to the pituitary tumor. So these same nerves innervate the coverings of the brain. So this is the dura, as I was talking about. It's called the sella. This is where the pituitary gland sits. And this is all innervated by the first and the second branches, so V1 and V2, which is why when somebody says their headache is right here, it's probably referred to this area by these same nerves. So here's a nice example of a tumor that was small, started to grow, and now is quite large, pushing the pituitary gland up. And so this is somewhat of a typical pattern. We generally don't wait for it to get this big, but it can happen. And when it happens, we'd expect this person to have some level of pain, but it really depends on how fast this happened. If this happened over a year, I think this patient would be quite significantly in pain or having headaches. If this happened in a day, the patient may be in a coma. So that's how significant this could be. But if this happened over 15 or 20 years, those nerves may have had time to adjust, and they may have had time to calibrate themselves and not continuously produce pain. So it really has to do with the rate of growth. This particular tumor has some cystic parts to it, some fluid-filled areas. So this may actually have variable rates of growth and can actually cause the pain to be a little bit more obvious. I think cysts are actually more common, as I mentioned, that can cause headaches. So this is an example of a Rathke's cleft cyst. This is another version of a Rathke's cleft cyst sitting on top of the pituitary gland. And this is how we would operate to take them out. We just kind of go through the gland. And this little procedure can relieve some of the pressure that's pushing on those structures and causing the pain. This is an arachnoid cyst. An arachnoid cyst is full of spinal fluid. And the way the spinal fluid, the cerebral spinal fluid, the fluid that bathes the brain, the way that fluid gets into this area is by a little hole in that dura that I mentioned, that covering that separates the pituitary gland and the brain. And the fluid goes in, and kind of like a ball valve, it gets stuck. So it gets stuck, and a little bit of fluid goes in and gives it a little bit of time. And over the years, this cyst can get quite large. So when we see this, typically these people have headaches, vision loss, sometimes pituitary dysfunction. And the way to treat this is by going in and draining the fluid and sealing up the leak. So this is an example. By the way, anybody here queasy and don't want to watch videos? There's a few of them. Let me know, put your head between your legs, whatever you need to do to get through it. This is an example of a patient with arachnoid cyst. And I apologize for the quality of the video. This was on a 3D endoscope, so you're only seeing one of the 2 eyes. So it's half as much resolution. But this is, first of all, you see the bone. The first thing that we took off was bone. It was paper thin. We didn't have to bite it at all. We just kind of came into it. This is the covering of the dura. This is the dura of the pituitary. And as soon as we pop in, all this fluid comes out. And that was the fluid in the arachnoid cyst. So we open it up so that we can get a little bit better exposure and allow it to drain a little bit. So this is what we're doing right now. And then we bring in the endoscope, and this is the part I want you to pay attention right here. Look right up here. You'll see that there's a little leakage of fluid right there. You saw that? That's the mechanism. So basically the fluid is coming through a little perforation at the top, and it drains into there and it gets trapped. So our job is to seal it up with some fat, and most of the time this is all that's needed, and you don't have to do anything further, and the cyst goes away. And the fat gets absorbed, so even though we're putting a big blob of mass there, it gets absorbed and scars down, and the headache goes away, and usually the pituitary gland function improves as well. So that's from dural stretch. But let's talk about trigeminal pain or trigeminal neuralgia. And this is a talk all on its own. I can talk about this for hours. But trigeminal neuralgia has been known to be called a suicide disease. It's when you have such severe pain because this nerve is irritated, and nobody can really find a cause. You know, you go to the dentist because you think it's your tooth. You go to the sinus guy because you think it's your sinuses, and you really can't find a cause. And the reality is it's because the nerve itself is inflamed. And so in these patients, up until probably 30, 40 years ago, we didn't have any really good drugs for this. And these people would go crazy, and some people would kill themselves because it was so severe. I was just talking to Ricardo Corral, who had an episode of this iatrogenically, and he said it was the worst pain he had ever felt in his life. It's horrible. So unfortunately, in some cases, a tumor can cause that, and we'll talk about this. So what is trigeminal neuralgia? It's a rare entity characterized by severe, sudden, brief, and usually on one side, stabbing pain in that trigeminal nerve. So either into the eye, to the cheek, or to the jaw, or a combination.
Dr. Barkhoudarian, is that the same? Because I had shingles, and it was on this side of my face, and that was the pain.
Mm-hmm.
They said it was on my.
Yes. So that's the same. That's the same nerve and the same type of pain, although yours is treatable with medications. So it doesn't fall into that category, but it's the same pain that they feel. Yeah, it's really bad. So so basically it's a condition where the nerve is really, really sensitive. And even a light touch or a light sensation like brushing your teeth or chewing or even the wind can irritate the nerve. And can cause severe stabbing or lancing pain. The drugs that work are actually anti-seizure drugs because they work on all sorts of nerves, and it works on the trigeminal nerve, and they tend to work well. But we always also want to make sure that there isn't a surgically treatable or other medically treatable cause. So the biggest cause of this actually is multiple sclerosis, and we always rule that out. But tumors, so either tumors in the brain area or in the cavernous sinus, which is that structure that surrounds the pituitary gland, or in Meckel's cave, which is the name of where the trigeminal nerve lives, those tumors can cause trigeminal neuralgia. And so what happens? So here's the nerve. This is the brain stem. The nerve comes off the brain stem, goes into the, it originates within the brain stem, comes off the brain stem here. It goes into Meckel's cave area, which is where the big nucleus sits. And then the branches come off. The branches go through the cavernous sinus, or right by the pituitary gland, and then it goes through holes in the skull to get to the brain, or to get to the face. And basically, the way I explain it to patients is it's a short circuit. The nerve is so inflamed that the covering of the nerve kind of is eroded a little bit, and the signals that come in from the face are caught in midway, and even the slightest signal will be interpreted as pain because the pain fibers and the sensation fibers are interacting. And this may explain why a very slight stimulation like the wind or chewing can trigger that severe pain. So this is what we would do traditionally. This is the traditional surgery for trigeminal neuralgia. This is actually not through the nose. This is behind the ear. We go in and we find the nerve. So that's the nerve that we see. And oftentimes it's just the blood vessel that's touching the nerve that's causing this pain. So we see that little red thing there, right there, that's the blood vessel, and it's pushing right onto the nerve. And we identify it, we use some special tools to dissect it off and to move it off of the nerve. And eventually, it's completely separated from the nerve. We use special pledgets, Teflon, the same Teflon you have on your cookware. We use that to separate the nerve from the vessels. We use Teflon because it's non-absorbable, so it just stays there forever. And here's the endoscopic view. That's actually the nerve for hearing, and the trigeminal nerve is way over there. There it is over there. And you see a large vein, but more importantly, the blood vessels that are in the area. And so we carefully separate the vessels, and you'll see the little pledgets that we put in to hold them apart.
Are you doing this through the nostril or through a crane?
This is from behind the ear. This is the view from a craniotomy from behind the ear. And with the endoscope, you get a nice panoramic view. So we actually have borrowed the endoscope from the nose and put it back there because we're so used to that view. And that's the Teflon. That little spiderwebby material is Teflon. And that's just a little glue that we put on there so that it stays in place. Probably don't need to do that, but we just like to make ourselves feel better. So that's how it works. And this surgery works 95% of the time for people who don't have a tumor or other cause. But say you're this person who does have a tumor in that area. So this is a 59-year-old woman with right-sided facial pain, trigeminal neuralgia, and you see this large tumor, and this is Meckel's cave. So this is where that nerve comes in. You can actually see the tumor has actually gone into the nerve all the way to the brainstem. So that's the brainstem. That's the nerve within the skull, or within the brain area where the fluid is. And that's the nerve within Meckel's cave where it's kind of where its home is. And it's all inflamed or looks like it's involved by a tumor. Well, this patient also had severe pain on that right side. So this is through the nose. And we go in, and I'm just going to orient you so you know, the pituitary gland is way over there. But it's right next to it. This is a few millimeters apart. And this is the carotid artery. This is the main artery that supplies blood to the brain. And we've opened up this area here where the nerve lives. Oops. And we'll go ahead and play that video. And you'll see how we do it. So we just make a little incision, and we open up the covering of the, this is also dura, so the covering of the nerve this time. And we do a little dissection to move it off. And you start to see these little fibrils. That's the nerve. You were directly seeing the nerve in that area. But this nerve is actually being plastered forward, and there's a tumor. So we identify this, and in this case, we biopsied it, and the pathologist was able to evaluate it during surgery and told us, wait a minute, guys, this is a lymphoma. So in a lymphoma, it's very sensitive to medications, to chemotherapy. So we did not need to take out the whole tumor, and the patient actually did really, really well with medications and with radiation, and her pain went away, and she's doing very, very well. So that's an example where the nerve can be irritated directly. What about dural inflammation? So what can cause dural inflammation or any sort of irritation of that dura? Infections, and that's probably the most common thing. Meningitis is probably the most common cause. The most common type of meningitis is from a virus, typical viruses that float around. But also bacteria can cause meningitis. So when we think of a meningitis in pituitary, we think, well, wait a minute, we did surgery and we introduced the bugs during surgery, or there may have been a cerebrospinal fluid leak and the bugs climbed up through that. But there are cases, and I'll show you one, of people who've presented with meningitis without having surgery but had a lesion around the pituitary gland. And then there's inflammatory conditions that are direct inflammation of the pituitary gland, and it results in inflammation of the dura around it. And all of these can cause headaches. So sarcoidosis, Wegener's vasculitis, temporal arteritis, and actually inflammation from surgery itself can also result in dural irritation. This is a lady who had meningitis. So she was 62-year-old, presented to another hospital in another city. I won't tell you which city, but they have lots of slot machines there. And she had this big tumor, and I'll show you the tumor in a little bit. She was treated with steroids, but her main symptoms were headaches. They initially got better with steroids, which is what headaches will do even if they have meningitis. But then she developed a fever, and then her platelets went down, and she was started on antibiotics. They thought she had some sort of cancer. This is what she had. She had a big tumor here that was on the skull base. So that dot right there, that's actually the normal pituitary gland. And the tumor is this big structure all the way around. And it's pushing into the brainstem, and it's going all the way into the nose, all the way down to the floor. That's at the skull base, at the lowest part of the skull base. It's a big tumor. But you can see there's a direct communication with the tumor and the nose. So already we can see what's going to happen. And this is the CT angiogram. You can see there's some vascularity and some calcifications of this tumor. Well, she came over here, and she was found to have a high white blood cell count, so it's a sign of infection. Her platelets were low, also a sign of an infection, and her sodium count was low, also a sign of a meningitis. Her pituitary function actually was thought to be normal, but she had been on steroids, so she may have actually been a little abnormal there. She was found to have bacteria in her blood, and then she had a spinal tap, a lumbar puncture, and she was found to have bacteria in her spinal fluid as well. So that's meningitis. This is the definition of meningitis. So what happened? She had a communication from inside to outside, and there was probably a small leakage of fluid into her nasal cavity. At the same time, the tumor itself was trapping off fluid, causing a little sinusitis. So she had sinusitis and a direct communication, and she ended up seeding her cerebrospinal fluid and getting meningitis. And you can see some signs of that here with enhancement of the dura. That's the dura right there. It should not enhance like it is there or there. You can see enhancement throughout. And you can also see some spots of microinfections there throughout the brain. So this is what we did here. I'll show you. A lot of the work here is done. Many of you have met Dr. Griffiths. Dr. Griffiths spent probably 3 or 4 hours doing the approach just to get us there and taking out a lot of this tumor on the way there because a lot of it's in the nose. And then we came in and identified the rest of the tumor in this area. And this is a long video, so I'm just going to speed things up a bit. So here we are. So this is, actually let me pull it back just a little bit. So this is where the tumor is starting to come out of the dura. This is that interface. And you'll see that there's kind of a clean, sharp margin there. There it is. So there's the dura. That's that white structure there. And there's the tumor right there. And we're showing us on our GPS system in surgery. This is kind of our navigation system. And we know exactly where we are. And so there's the tumor in the center. And the dura is the round thing around it. And so now we have to remove this tumor from inside. This is where we have to slow down. So Dr. Kelly and I come in, and we carefully, very carefully, shave a little bit of tumor off, separate it from the brain, shave a little bit more off, separate from the brain, because this is where you can't do a lot of pulling and pushing and bigger moves like that. But as we start to debulk the tumor, we go a little bit more forward here. So there's the insides of the tumor. So we're kind of working inside out here, and we're just kind of shaving down the tumor here. And we're already starting to see some structures flowing through the tumor. So that's a very important vessel that's actually engulfed within the tumor that we were able to save. And we're going to start to see the brainstem in this area. So those are the key structures and nerves and parts of the brain that keep you alive. So they keep you breathing and keep your heart pumping and things you don't even think about. So you're starting to see it sneak up there. You start to see the fluid, the cerebrospinal fluid there as well. And I'll get to the back part here. There we go. So this tumor actually had hemorrhage, had bled, and was quite inflamed, and was stuck to the brain. So we actually had to leave a little bit behind. But there's the interface between the tumor and the brainstem here, and those are the nerves that are going to the face, and the nerves, the trigeminal nerve is up there. And those are some blood vessels that we aim to preserve. So this one big tumor was presented with a headache, but the headache was mainly because of meningitis, not because of mass effect, because once we treated the meningitis, the patient got better. This is her afterwards, and she did really well. But other types of inflammatory processes can occur. So here, some of you are familiar with looking at MRI. So there's the pituitary gland there. You know, the nose is about here, the eyes are about here, and the pituitary gland lives there. But it shouldn't be this bright with contrast. It should be a little bit more gray. And it's quite bright and quite enhancing. And also, this structure here is enhancing. This is the normal dura, and the normal dura is enhancing as well. And when we see something this thick and this enhancing, we have to worry about an inflammatory process. And this person had sarcoidosis. Sarcoidosis is an autoimmune process that tends to attack the body. Very, very treatable with anti-inflammatories, believe it or not. And you don't really need to do surgery for this, so it's important to differentiate. This is a patient with another type of autoimmune condition, Wegener's granulomatosis, or Wegener's vasculitis. I think they've changed the name recently. But you can see the pituitary gland was inflamed, but actually crept up and it started to cause inflammation of the optic chiasm, so the nerves from the eye were getting inflamed. And this person was losing vision and had loss of pituitary function. And this patient was really refractory to the standard medications, which are steroids and some drugs that we use for rheumatoid arthritis. But she ended up getting another drug called Rituxan or rituximab, and that actually treated her inflammation really well. So this is within 7 days, you see already a shrinkage in inflammation, and at 3 months, much, much smaller. Patient did much better. This patient also presented with headaches in that area. So we'll move on to hydrocephalus. So hydrocephalus is somewhat different of a process than all of the other tumor processes we were talking about. But to understand hydrocephalus, you have to understand some of the normal physiology of the brain. So what does it mean? Hydrocephalus literally translates to water on the brain. And it's basically because of dysfunctional cerebrospinal fluid circulation. And these are some of the acronyms we use. This is the brain's circulatory system. So spinal fluid is in each of these structures here. These are called ventricles. They're different from the ventricles from the heart. They're fluid-filled structures in the brain, and they give the brain, not only do they make the fluid that bathes the brain, but they give the brain some buoyancy so that the brain stays light and floats in the fluid. And it actually has, it's kind of a little pressure sink, so that if the brain moves a little bit, it'll deform a little bit and allow the brain to move around. So it's a little bit of a safety thing as well. The fluid is produced by this structure here called the choroid plexus. And the choroid plexus is called choroid because it looks like coral from the ocean. And this basically produces fluid that starts here, goes down through this hole called the foramen Monro. There's 2 of them. And it goes through the third ventricle. So there's 2 lateral ventricles, goes through the foramen Monro into the third ventricle. And then it goes through this little aqueduct called the aqueduct of Sylvius, or the cerebral aqueduct. And then it goes into this other ventricle called the fourth ventricle. And it comes out of 3 holes, the foramen Magendie and the foramen Luschka, which are outside the plane of the screen. And then the fluid goes and circulates all the way around the brain, all the way down the spine, and all the way back up the spinal cord. And then it gets absorbed in these little granules called the arachnoid granules that gets the fluid absorbed into the bloodstream, and then it goes back. Now, I'm not going to ask you to remember this. You're not going to be tested on all this. But the one thing that one should take away from all this is the process that the fluid is made in the ventricles. The one thing you should take away from this is there is no off switch. There's no way to turn this off. So the brain knows how to make it. It doesn't know how to stop making it. We have some drugs that can help slow down production, but there's no way to turn it off. So I'm going to take a little aside and tell you a little story. A while back, I was in medical school. I was part of this medical history organization led by this guy here, Bob Bartlett. He's the guy that invented ECMO, you know, the thing that keeps little infants alive, like a heart bypass. And he also invented the incentive spirometer that many of you may have used to, the thing you breathe in after surgery to help reinflate your lungs. That's him. Really nice guy, well known around the world. And he had us go all over the world. And we went to France, went to the Institut Pasteur. They had a great museum there. Actually, I stopped by the catacombs because it was really cool to see all these skulls and whatnot down there. But in the museum, we saw these things. And at the first glance, you say, wait, these guys are aliens. But they're not. They're people, they're kids actually, who died from hydrocephalus. Because in kids, the skull can actually deform to the size, to the pressure of the brain, because the skull is still developing. And these kids end up getting very, very large skulls, and then ultimately they succumb to their disease. But it's very similar to our modern day aliens that we see, and I bet you what they saw in Roswell was actually a kid with hydrocephalus. But how do we treat these? There's, as I said, there's no off switch. So the only way we can treat this is by moving the fluid aside with what's called a ventriculoperitoneal shunt, or a shunt of any sort. But basically that's a catheter that goes into that area, comes underneath the skin. Usually there's a valve that helps regulate the flow, and it goes all the way down to the belly, or we can put it into the vein that goes into the heart, into the lungs, any place that can take fluid. And this allows the fluid to drain away. That's the tried and true method. Another method is to bypass the blockage. So say the blockage is over here in the brainstem. Well, we can create a new opening here with an endoscope, and we come down and we open this up, and allows for fluid to drain in a different way, and allows the pressure to relieve itself. But the ideal way is to just get rid of the blockage originally. And we can see that with various types of tumors, and the most common is either a craniopharyngioma or a large pituitary adenoma. I'll show an example of a craniopharyngioma. So here's a 31-year-old woman that came initially to another hospital with hydrocephalus. So they did the right thing. They put a shunt in her to save her life, because that was going to kill her. But she presented with headaches, vision, and memory problems, and that was the cause, the hydrocephalus. We don't see the hydrocephalus anymore because the shunt is in place. Then she had a big brain surgery from above to try to take out the tumor. There's a shunt. But they really couldn't get to this. They weren't able to reach this. So they did a little biopsy. They found out this was a craniopharyngioma, and then they sent her to us. She came in, we'll ignore all this here. She came in, and the shunt was infected. It was eroded, the wound hadn't healed well, so we had to remove the shunt, and we had to place a drain in place to temporize the fluid. And then we went through the nose, and we debulked the cyst to allow the fluid to drain. And we were able to actually remove the drain ultimately, and she didn't have to use a shunt anymore. And she got radiation to the tumor. And actually, her tumor's been under control for, actually, it's more than 9 months. I think she's now 15 months out and doing really, really well, with no recurrence and no hydrocephalus. So she was able to avoid a shunt. And anybody who's had a shunt will tell you it's kind of a pain in the butt. They can get infected. They can stop working. Anytime you have a fever, you have to go to the ER to get a spinal tap, and it's not a pleasant thing. So if you can avoid a shunt, that's better. So I always like to show this slide, because this is more educational for our residents, but I like to show it to most people, because I ask the question, what's the most commonly missed lesion? And the resident sits there, and they're trying to think of some zebra thing, like, oh, an aneurysm, or, oh, and histiocytosis X or something like that. Well, we saw this patient. This guy is let's make sure he's not here. This guy is a nuclear physicist, brilliant guy, and came in with a pituitary tumor and some hormone problems. And he had some headaches, not really bad headaches, just really mild headaches. Do you guys see what else is going on? Almost looks like there's two tumors. Yeah. There's the pituitary tumor, and then there's this thing up there. Yeah. This is called a colloid cyst. Colloid cyst is made of the same thing a Rathke's cleft cyst is, but it's up in the ventricles, and it blocks flow, and it basically causes hydrocephalus. And this is a person who had not only a pituitary tumor, but blockage of the flow at the foramen Monroe. And so when I ask, what's the most commonly missed lesion? It's the second one. It's the one you're not thinking about, and you're focused on this and you miss this one. Well, this is how we treated this patient. Not through the nose for this. We first treated this tumor because we were worried it was going to cause too much pressure, and if you got a CSF leak from the adenoma, then we would have a hard time sealing off the CSF leak. So we wanted to treat this endoscopically, and here's our endoscope. We're actually in the ventricles, and you can see the choroid plexus there. It really does look like choroid. It's floating around there, and it looks really pretty. And that was a cyst hiding under there. This is the choroid right there, and we're using a special device to shrink it away and cauterize it. And you're going to start to see the cyst sitting right there. And this is also a longer video, so I'm going to speed this up just a little bit. Charmin, am I okay on time?
Yep, you're fine. Yeah.
Okay. And so now we have this device that kind of chews up the tumor a little bit. And, or the cyst, I'm sorry, it's not a tumor. And you'll see that we're able to chomp it up a little bit, little by little, and then all of a sudden we're going to enter the cavity. So here's our scissors. We come in there, and we're able to cut into the capsule. And there it is up there, way up in the corner there. As soon as we cut into it, all this goopy stuff comes out. That's the fluid-filled part, very, very similar to a Rathke's cleft cyst. And this person, much like most people that have a colloid cyst, have some firm parts to it. And we see that in Rathke's cleft cyst as well. And we have to take those out in a kind of a piecemeal fashion. And I'm just going to skip to that part there. There we go. So you see those solid parts there? Those are the parts that are a little bit harder to remove. We're able to grab them and use this device to remove the rest of the, there it is, to remove the rest of the part. And after surgery, the patient did really, really well. Let's skip that part. There we go. So after surgery, the patient did really, really well. We basically removed this whole structure, and we delayed his surgery about a month, and we did the tumor about a month later. And his hormone functions have started to come back. It a really complicated course because he had hormone dysfunction, and he had headaches, and he had these 2 operations. So it took him a while to recover, but he ended up doing well in the long run. All right, so the last thing we'll talk about is pituitary apoplexy, because this is probably the most dangerous type of headache associated with a pituitary tumor that you can expect. And everybody should know about it. Tell your friends, tell your loved ones. This is a patient that we recently operated on, 43 years old, awoke with acute left eye vision loss about 3 weeks before, for about 3 weeks, and he had pain behind his eye, really kind of severe pain. He was seen by Dr. Kraus, Howard Kraus, and was found to have vision loss. And the MRI.
Neuro-ophthalmologist, so in case anybody doesn't know Dr.
Oh yeah, sorry, that's a good point. On his neurological exam, his only finding was that he had loss of vision in the left eye. OS means left eye, and he had decreased vision in his left eye. Dr. Kraus, who, if you have met, is probably one of the most detailed physicians I've ever met, and he did an amazing visual field test. He actually drew these out by hand, and you can see the visual field deficit right there, caused by this tumor. And he also had hormone dysfunction, so he had hypothyroidism, mildly elevated prolactin, but that's normal. But he had low thyroid function, and here's his tumor. So you can see without contrast, there's some fluid levels there, and there's a big cystic area, so that's actually blood. And when we give the contrast, we can see it's not homogeneous, which is what we normally would expect for a pituitary tumor. So this patient had pituitary apoplexy. So he had headaches, and he had a vision loss, and he had hormone dysfunction. So all 3 together. And so this was an interesting study that looked at patients with apoplexy. They looked at 47 patients with apoplexy and 46 patients without apoplexy. And they were looking at various things. But I think the most important thing is most patients presented with headaches. And usually their headache was severe onset, sudden onset, really bad headaches. And all of the other symptoms they would get were coincidental with the headaches. So the vision loss came as soon as they had the headaches. They felt really weak and fatigued as soon as they got the headaches. And some of these patients had other problems, like what's called oculomotor palsy. So that means that the eye wasn't being controlled well because some of those other nerves that I showed you were being affected by the impact of the bleeding in the pituitary gland as well. And so here's this patient who we were operating on him a few days afterwards because it was kind of a chronic process. Generally, we would take these patients to surgery that same night because we want to preserve vision as best as possible. And here is our opening. Again, that's the dura. That's the dura that covers the pituitary gland. And we elevate it, and we see this tumor here. And we carefully separate the tumor from the pituitary gland. You can see the tumor is actually quite soft. It's kind of a consistency of tapioca. It's very soft and very easily manipulated. You'll see at some point when we get into the cyst that some fluid rushed out. And that was the partially processed blood that was coming out. And then the rest of the surgery was really just to debulk the tumor. And at this point, the pressure is actually off the nerve, so we have a little bit more time. And we're able to, there's a little bit of spinal fluid leak from the tumor being stuck to the coverings. And then we're able to carefully separate the tumor from the surrounding structures. And we were able to remove this completely. And there's us. So that's the dura of the cavernous sinus. So those are where those nerves live. And we're carefully finding the plane to maneuver it off that area. And I don't know if you can tell, but that kind of wedge-shaped thing that kind of looks like a liver, that looks different from the rest. That's actually the pituitary gland. So we are actually able to see the pituitary gland and carefully separate it from the tumor with this endoscope and with our tools that we have here. And that's really key because we want to preserve the pituitary gland as best as possible so that the patient has the best chance for an endocrine recovery. Oftentimes, patients with pituitary apoplexy come in with severe hormone dysfunction, but some of them improve. And if we can get them in time and the damage hasn't been too severe, we can reverse some of them. Not all the time, about half of the time, we're able to get some improvement in these patients. So this is just the kind of final touch-up, removing any last bit of tumor that we can see. And then we start our closure. And this person needed some fat. Oh, that's actually, those of you guys in the beautification industry, that is, let me show you in 1 second here. That is actually hydrogen peroxide. It's the same peroxide you use for your hair. And we use that because not only is it bacteriostatic, so it helps clean up the area, but it helps stop the bleeding. And we think it helps kill the tumor cells that are left behind. And then there we are with some fat and piece of bone to hold everything together. And that's just a collagen sponge that Dr. Griffiths takes out later on when he does the nose cleaning. But we like to keep it there to keep it separate. So this particular patient did well after surgery. Right after surgery, his left eye's vision improved dramatically. And his hormone function actually was normal after surgery. And this is the before of his visual field. You see that deficit? I think this was only a few weeks afterwards, and that improved dramatically. So again, thanks to the wonderful artistry of Dr. Krause. So pituitary apoplexy, the headaches are usually sudden onset. Patients will say, these are the worst headaches of my life, or this is the worst headache I've ever had in my life. It's like a gunshot to the head. And you hear that, call 911, they need to go to the emergency department. Vision loss, usually sudden onset, usually bilateral, meaning tunnel vision, but you can have any sort of combination, one eye, the other eye, both, etc. Hormone dysfunction is common. And people can't really pinpoint it, but they just feel really wiped out. They just say, Doc, I just have no more energy. I don't know what it is. And when you hear that, you got to be worried about low cortisol, low thyroid function. And the other neurological problems can occur. So double vision, facial pain, numbness in the face, even in severe cases, neurological problems can occur as well. And so the bottom line is this is a surgical emergency. When we have a patient like this, we take him from the ER straight to the operating room. Do not pass go, do not collect $200. I mean, it really is a serious issue. And most of these patients, they regain much of their vision, and some of their hormone function will improve, and their headaches get better. So really treatable. So this is my summary slide. These are things that anybody should know when it comes to tumors in the brain. So beware of the headache that wakes you up. So if that's the cause of you waking up, not that you woke up and, oh yeah, you had a headache, but the headache woke you up, that's concerning, and that's something that needs an evaluation. Headaches that tend to get worse and worse and worse, progressive headaches, those are ones that we want to know about, because those are things that can crescendo and can be related to either a growing tumor or hydrocephalus or a combination. However, size is not everything, and it's actually the rate of growth. So you can have a 2-centimeter tumor that's causing headaches because it's grown over the past 6 months, and you can have a 6-centimeter tumor that's not causing headaches whatsoever because it's been growing for the past 20 years. So along that line, a cystic tumor can definitely be contributing more to headaches than a non-cystic tumor, and patients with hydrocephalus tend to have more headaches than those that don't. And the most interesting thing from my perspective on that front is that by just treating the hormone hypersecretion problems in the patients with acromegaly, Cushing's disease, prolactin secreting tumors, that on its own can actually help with the headaches, separate from taking the tumor out. So really interesting there. So with that, I'm going to leave you to ask any questions, anything that may have come up during my talk, or anything you want to ask me at all. Thank you very, very much.
Dr. Barkhoudarian, before you leave, I want you to look at this real quick. But anybody else has any questions?
Sure.
Let us know.
Any questions? I think I stayed within the time limit. Did I?
Yeah, no, it's good.
It's very rare. I'm Armenian, and we tend to go outside, run late.
Awesome.
Yeah. You have a question?
I remember one of the first slides, there were like 6 different areas of headaches, and the
Oh, yeah.
top middle one, you don't have to go back.
Yeah.
They were great in areas like in between the eyes, but also the ear.
Mm-hmm.
And does that mean that patients also complain about earaches? Because that was in my case, that the doctors were laughing at me.
So if,
I felt like I had a chronic ear infection for 1.5 years.
yeah.
Until the tumor was discovered.
So there's a few reasons for that. It could be from the sinuses, or it could be from the tumor going outside, sideways, basically. Instead of going up or down, going sideways. And the sinuses are probably a little bit more common because the pituitary is right by the sphenoid sinus. The sphenoid sinus is right by the eustachian tubes. And the eustachian tubes drains fluid from the ear. So if your eustachian tube gets inflamed, then you get earaches. And so all it takes is a little bit of fluid to do that. And then the tumors going sideways into that cavernous sinus area that I mentioned, sometimes can even go more farther into that area. Those tumors can also present with headaches on that side.
It wasn't though when they found it.
But did your headaches get better after surgery?
The headaches, yes. The earaches are still kind of there.
Okay. Could be unrelated.
It's on the same side where the tumor was, and I have like chronic earache.
I bet you it's eustachian tube. That's my thought. But we'd have to look at that. Yeah.
Okay,
Yeah.
thanks.
So if someone has constant headaches,
Uh-huh.
do they need to go, I mean, that kind of headache, do they need to go get an MRI just to see if it's a tumor, or?
So it depends on who you ask. If you ask a surgeon, yes, everybody has to have an MRI. There's no cost in the world that will stop that out. But obviously, that's going to be very expensive. The reality is lots of people have migraines. Lots of people have tension headaches. You don't need to get an MRI for any sort of headaches. The headaches that I think one should start investigating is either a headache that's just always there and just not fitting into a particular category, like it doesn't really fit a migraine, doesn't really fit cluster headaches or some of these known headache syndromes, that probably needs an MRI. A headache that's associated with something else, so headache and vision issues, a headache and fatigue, a headache and seeing auras and things like that, those probably need an MRI to be evaluated. And the more severe things are headaches that wake you up in the morning or just wake you up in general. Those, I think, definitely need to get an MRI. A headache that is just getting worse and worse and worse and is not responding to the usual medicines, those need to get a scan. And I think it's not hard to get an MRI these days. It used to be, but it's much, much easier now. So I would rather err on the side of getting the MRI than waiting 2 years, 3 years, and now the tumor is twice as big and then more invasive.
But I also want to comment because a lot of patients will have headaches, and then they'll scan them, and there will be a small tumor, and then the doctor says, oh, those are unrelated to your headaches. But then you have to go back to the fact that are they getting a proper workup with hormonal function and things like that. So that's where I see a lot of patients going with headaches, these horrible headaches, and then they see a pituitary tumor, but they don't want to do anything, and then they don't have the proper workup, and they are causing a problem.
I think that's a good point. And we didn't even talk about that. I mentioned, I think in one word, incidentaloma. So as I mentioned, 20% of people have something abnormal in their pituitary gland. And lots of people have headaches. So if you do an MRI on everybody, you will find something abnormal. You'll find a little cyst or a little microadenoma or something abnormal in that area. And so it's our job to try to figure out, is that the tumor that's causing the headaches, or are they unrelated? So this is where we sit down with you guys and say, well, where's your headache? What's the characteristics? Have you had MRIs before? We'll go back, 5 years and, oh yeah, the tumor was there before, and so we can compare and say there's been no change, but your headaches only started a year ago. So that's some information that can help us. And in some cases, we'll just monitor that, and if the headaches get better on their own, then we can say, well, they're probably not related. Yes?
What effect does alcohol have in inflaming headaches? And I'm not talking a lot. Before I had my surgery, if I had 2 drinks, it would really create a problem as far as headache pain. And now I can.
Well, so you're having it right after you drink or the next morning? I think alcohol can do a few things. One, it can actually drop your blood pressure a bit, so in the immediate stage. So it's possible that alteration of blood can exacerbate a headache. It could dehydrate you, and we know that dehydration on its own can induce headaches. So it's possible that it can amplify whatever headaches you may have from other causes. But in many people who drink alcohol and have tumors, there's no correlation. So it could be unique to your situation.
It can be blood sugar too if you have diabetes or borderline diabetes, and alcohol raises your blood sugar at the time and stuff like that too.
It could, yeah. You can get that kind of dull type of headache you see. Yeah.
Anybody else?
Yep.
How long do post-surgical headaches, like residual headaches, just from surgery last, generally?
Good question. So that same institute, the Institute of Headache, the International Headache Society. You taking off? Okay. That's my wife Evelyn, by the way.
Someone's got to get home to the kids.
So that same organization has criteria for post-surgical headaches, and so their criteria is if the headaches persist longer than 3 months. Then after a surgery, and they weren't there before surgery, then that's probably related to the surgery. And then there's the whole issues of how to treat those types of headaches. For pituitary patients, we definitely see a small percentage of patients with chronic headaches. And part of that is due to inflammation of the sphenoid area, because you saw we packed that area with fat and other products, and sometimes that can get scarred in. This is when we call Dr. Griffiths or his colleagues and say, hey, listen, you need to go in there and clean things up. And that usually can take care of it. In some cases, the nerves can get inflamed, the trigeminal nerve, and so sometimes you need some special types of medications to help manage the pain. But typically it's 3 months. Thankfully, it's not that common, but some people definitely do have it, and we have some tricks up our sleeve to help with those pains. But my first stop would be to get a scan, make sure that there isn't a big sinusitis. Obviously, there isn't a big recurrence if it's a delayed headache, and treat those accordingly.
And then if they're on medications for, say, acromegaly or Cushing's disease, if it wasn't a complete resection, those can still kind of interfere sometimes with headaches too.
Yes, although that one study showed that
Yeah,
it
that
actually
one
got better. But
yeah.
some of the patients actually get headaches as a side effect of some of the statin, some of the octreotide analogs.
I've developed some strange headaches post-surgery, and I was operated the old-fashioned way through mouth and nose.
Oh, through the mouth. Oh, you mean under the lip?
Yeah,
Okay.
exactly. That is something that the doctor's telling me it's nerve pain from nerves that might have been cut. Sometimes I have severe toothaches that my dentist says there's nothing there. Or nerve pains, like the whole face is burning and you just want to take it off like a mask. And there's nothing that helps. Have you ever heard of similar cases? Or?
1 or 2 patients, yes. Usually it's a nerve issue. We can look into that. Yeah, we can talk about that.
Is there any particular remedy to this?
We'd have to do some imaging and see if there's any abnormalities. Sometimes
Well, the images seem to be fine. Dr. Kelly had a look at them.
he looked at them.
But your
Well,
face, he only looked at the brain. You didn't do the face, or?
No,
yeah.
he only looked at the brain
Brain.
that I.
Yeah.
Because you could you just check for her nerves here?
Well, but it's all over. So we work with some headache specialists, and there's certain types of medications that work for nerve pain that are totally different from the other medications we talked about. So we can talk about that. Yeah, but that's an unusual outcome, but it definitely can happen.